Okay, let's make sure that everyone is hearing well. So I just wanted to test the sound. Is it clear for everyone? Is the sound clear?
It's okay.
Shall we start? Okay. Okay, so today's topic will be around the complications that we might face doing lower blepharoplasty. And as we know, lower blepharoplasty has evolved recently from the simple transcutaneous to more and more fat preserving and transconjunctival approaches. And I think this evolution is related to the general trend towards doing procedures that might be less invasive, yet they would deliver the desired results. Each procedure, as we know, has its own risk profile. Complications in the lower eyelids usually arise when there's a disruption of the balance between the different tissues. And we have to understand very well that we are dealing with a very delicate and a very thin organ, having the thinnest skin, having almost the thinnest muscle in the whole body. As we know, we have two main approaches to perform a lower blepharoplasty, whether it's a transcutaneous approach or a transconjunctival approach. The transcutaneous approach is usually left to cases with severe redundant skin. And I mean severe is that those cases that you can pull a considerate amount of skin from the lower eyelid without any possibility of complications like ectropion or any deformity in the contour of the eyelid. Also, in cases of severe malar festoons, this is another indication to go transcutaneous. However, transconjunctivally, also you can manage those malar festoons. And of course, if you have any eyelid margin malposition or abnormality that you would need to go transcutaneous, and also there is some sort of redundant skin, that's when you need to go transcutaneous. As for the transconjunctival approach, it is almost 85% of my practice now. It's very useful in young age. It's very useful in cases that do have mild to moderate skin redundancy, where you can later on do other procedures to improve the texture and the integrity of the skin, like laser tightening sessions, like different kinds of injections that can work on improving the tone of the skin. Transconjunctivally, we can get rid of any complicated fillers, and we can even do a meat facelift through the transconjunctival approach. Let's discuss the complications and what complications could be prevented from the different approaches of the blepharoplasty. So we'll start with the transcutaneous approach. And we have early complications, which I mean that might be intraoperative or the first couple of days after surgery. First thing is hematoma and hemorrhage, and this you can easily prevent by proper hemostasis all the time and with gentle handling and manipulations of the tissues. Edema, and this is usually due to excessive dissection and lymphatic disruption, and lymphatic disruption might be caused from excessive cauterizing or diathermy in the tissues of the eyelid. So I never suggest doing that. And another thing that I believe you can prevent pretty much is the possibility of infection. And this honestly has two sides. The first side is the operative side, where you need to do the surgery under very clean circumstances with a very good hygiene, but also the patient is responsible for such a thing, so that sometimes we are under the mercy of the patient's compliance. As for the late complications, the transcutaneous approach is the nightmare of the ectropion or the lid retraction, or even many times we find the cases that did transcutaneous blepharoplasty and they're not happy. Why? Because the shape of the eyelid changed a bit. And that's why I always encourage to give a priority to transconjunctival blepharoplasty, much better to just go through the skin. So ectropion is usually due to excessive skin removal, is due to anterior lamellar contraction or posterior lamellar scarring, which again can be easily avoided by preventing ourselves from growing transcutaneous in cases that don't necessarily need anything to do with the skin. Again, scleral show, which is the same thing, it's more of an aesthetic issue, and this might cause some sort of exposure, or it might cause incomplete blinking of the eyelids, which will lead to some sort of discomfort, dryness, and etc. Visible scar or pigmentation, part of it might be the responsibility of the surgeon, part of it might be the healing process of the patient, which again, in cases that do not need transcutaneous, I would avoid such a risk. Over or under correction and orbicularis dysfunction, this is due to excessive muscle scarring. Transconjunctival complications, we have early complications, which is conjunctival edema. It fades away and it subsides. Retrobulbar hemorrhage, and that's why I always encourage handling, like the video, handling the fat pads in a very decent way. I stopped using any arching forceps. I can hold the fat pad as seen in the video, and then doing some cautery and then cutting and gently manipulating the fats. This is a very important point, because any aggressive handling of the fats can cause small bleeding in the deep vessels of the fat pad that we do not see, and we get the patient the following day with this nightmare of retrobulbar hemorrhage. So this could be also avoided intraoperative by gentle handling of the fat pads and the inferior oblique injury. And I believe I'll show a video to the technique of the surgery. If you're working in the right plane and you're parallel or tangential to the fat pads, I don't think there is a possibility to injure the inferior obliques. Late complications in the transconjunctival approach are again over or under correction, infection, or conjunctival scarring or inclusion cysts in the conjunctiva. And all of these honestly are complications that could be easily avoided and even corrected, unlike the transcutaneous. Okay, so here are some pictures of the transcutaneous approach that I think the photo speaks by itself. This is not a scenario we would like. There is a scar, there is ectropion, there is scleral show, there's everything. Same thing. I believe even if you do a canthopexy to prevent such a thing, there is still a possibility for an aesthetic show, scar, scleral show, some sort of ectropion and everything. So I believe all of this could be avoided by simply choosing the appropriate technique. As we can see, this is a table also comparing the complications and the possibility of the complications between the transcutaneous and the transconjunctival. And as you can see, most of the transconjunctival possibility of complication with transconjunctival is way less than the transcutaneous, except the only thing is the inclusion cyst, which might happen. However, it's very rare if you properly do proper alignment to the conjunctiva after the surgery. I never take sutures in the conjunctiva, and I believe I only had 2 cases of inclusion cysts, and sometimes they go by themselves or they need some drops and medications. This is the video for the transconjunctival approach that I usually perform. First thing, we do the incision between the tarsus and the conjunctiva deep enough so that it facilitates the next step, which is dissection and cutting through the orbicularis in the direction of the orbital rim to expose the orbital septum and start expressing the fats out of their place. As you can see, we go directly towards the orbital rim and we can start seeing the fat pads. We all know that in the lower eyelid we do have 3 fat pads: a medial fat pad, a central fat pad, and a lateral fat pad. We'll start identifying. This is the medial, the central, and the lateral fat pad. Fat pad is in another position, which is more anterior and superior towards the skin. Here's the lateral fat pocket. We start gently expressing the fat pads. I do not open big openings in the septum. This also helps in maintaining the proper position and the proper function of the eyelid. And I also avoid too many manipulations disrupting the normal balance between the tissues. We express the enough amount of fat that we feel that is needed to be removed. What I always do is that I preserve some fats, and this is very important in the process of maintaining a natural volume and a proper aesthetic outcome. So as you can see, there are some fats. It's very tempting to remove those fats, but this is the first step in creating a post-operative hollowness, which is also something not advised and something that the patients do not like. Later on, I do cauterize the fats that I decided to preserve, and the fats are very well rested over the orbital rim, preserving and forming a very nice volume. This is the position of the inferior oblique muscle. It's between the medial and the central fat pockets, and again, it's very deep, as you see. I don't think we need to go that deep. Following the same steps in the video that I showed you, there is no possibility to insure the inferior oblique muscle. Those are some results for transconjunctival approach, and I want you to take a proper look about the texture of the skin. In many cases, many patients and even some doctors might argue that doing just a transconjunctival approach will lead to more redundancy and more wrinkling of the skin. This does not happen. I did not touch the skin in all these cases. Same case, this lady, we can see we had a deep tear trough before the surgery. We take advantages of those fats and we do a proper preservation for the fats with maintaining a very good volume. Same thing, pre-operative, we can think that there are some lines, fine lines. Please do not run after fine lines. This gentleman, we can see lots of skin folds and lines, but yet this picture, the after photo, is only 2 months after surgery, and they still get to improve along 6 months. So I don't think there is any need to run towards the transcutaneous approach, except in specific cases. The golden rule is less is more. Treating complications is not something we want to do, but managing our surgeries and doing small modifications is much easier. Under correction, over correction, all of these things are easily handled much better than doing complications. And then the thing is that you lost the trust of the patient, and you lost the patient, and it might even affect your reputation. Respect the anatomical layers, customize approach per patient, preserve the orbicularis and the canthal support. This is in cases of transcutaneous. Fat preservation and repositioning over removal, it's much better. Gentle handling of fats in cases of transconjunctival, it avoids any possibility to retrobulbar hemorrhage. Ensure proper post-operative care, lubrication, tapping and massage, and follow-up. Lower blepharoplasty is a very rewarding procedure, but has its debts sometimes. Prevention of complications is much better than dealing with complications, and the objective always is rejuvenation with function and identity preservation. Thank you very much. I think we are open to questions. If anyone from the audience has any question, please, I'll be willing to answer. So to do camphopaxy, it's much easier if you're doing both an upper and lower blepharoplasty, because you can easily pass choline sutures from the lower eyelid and doing a sort of a vertical support towards the orbital rim in the upper part of the eyelid. But if you're just doing a transconjunctival approach, you can have a very small opening in the lateral part of the crease of the upper eyelid, and through it you can still do the camphopaxy. الأدوية اللي بنديها بعد العملية، بندي طبعا مضاد حيوي، أي برود سبيكتروم أنتيبيوتيك، وده بناخده لمدة 5 أيام. لو في جرح خارجي على الجلد بناخد طبعا مرهم. usually أنا بكتب حاجة combined، يعني أنتيبيوتيك مع ستيرويد، ممكن توبرادكس، ممكن طبعا لوبريكانت دروبس، وممكن حاجة بس للتورم والإديمة وكده، أي حاجة ألفا كيموتريبسين، ألفنترن، أي حاجة أمبيزيم. والكمادات الثلج مهمة جدا 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 أول 30. So yes, this is the same question. The post-operative medications are in the form of oral antibiotics for 5 days. If there is any scar towards the skin, we prescribe an ointment that is an antibiotic and steroid. Lubricant drops. In cases of transconjunctival, we add also some antibiotic and steroid drops like Tobradex. Ice compresses or ice fomentations is very, very, very important. And after 2 weeks, if there's any scar on the skin, I start using silicone gels. How do you close your conjunctival incision? I do not. I leave it. I do not need to take any stitches or any sutures in the conjunctiva. I leave it and it completely heals within 4 to 5 days without any trace. Like if you ever, this patient, if they ever went and examined the lower palpebral conjunctiva, no one can tell that they had a surgery. في حال كان الجلد تحت الجفون السفلى مترهل وفي زيادة، هل ممكن نشيل من الجلد الخارجي أم لا، وخصوصا عند كبار السن؟ ممكن نقيس الجلد بس بعناية، وممكن برضو نعمل تكنيك تاني ان احنا نخش ترانسكونجنكتيفال، نوزع الفاتس بصورة مظبوطة، نشيل الفاتس، وبعد كده بنعمل حاجة اسمها بنش سكين اكسجن، يعني بنعمل بنش ونشوف ايه كمية الجلد اللي فعلا سيف ان احنا لو شلناها ما يحصلش اي ضعف او اي اكتروبيوم او اي تغيير في مستوى الجفن نفسه. فممكن من الاول خالص نشتغل العمليه كلها ترانسكوتينيوس، وممكن نعمل ترانسكونجنكتيفال ابروتش الاول، وده يوجوالي اللي انا بعمله، بخش ترانسكونجنكتيفالي اشيل الفاتس اوزع الفاتس، وبعد كده لو حاسين ان احنا في شويه جلد محتاجين ان احنا نتعامل معاه فممكن نتعامل معاه، وده بيسهل برضه نوعا ما وبيقلل احتماليه ان يحصل اي كومبليكيشن من ازاله الجلد زياده، وملهاش علاقه بصراحه بموضوع السن خالص. Hemosiderin pigmentation is one of the very annoying complications. It's very rare, honestly. However, it needs time. Recently, I've been trying to see the effect of injecting some kind of skin boosters, and I found some promising results. If they're promising enough, I might share the results of injecting. It's rare, however. This year I only had 2 cases, but it needs proper counseling, and you need to inform the patient that it will take its time, and it usually does fade away. There are some laser sessions, however, it's still controversial. It might worsen the condition in many cases. What about the wound dressing? I never apply any dressing on the wound. I never put any strips or anything. I leave it and I cover. I ask the patient to regularly put the antibiotic ointment over the stitches. In what cases do you decide to do fat grafting and transposition? Fat grafting will only be applicable when you have preoperatively severe holes. But in cases where you have extra fats, I would always take advantage of those fats in transposition and preservation of the fats so that I can maintain a proper volume. So again, fat grafting is in cases, or you might need fat grafting if you did some overcorrection, so that you get a patient that they have some puffiness in the lower eyelid, and then you removed fats more than necessary. That's when postoperatively they might have some sort of hollowness. That's when, on another setting, we have another question here. How to decide the amount of fat to be removed? This, I would say, needs a bit of experience, so that with time you will know the amount of tissue. But one tip I would always give is that it's much better to be undercorrected than overcorrected. Okay, and it's always easier to correct something small than having something major and to correct. So if you're in doubt, always be on the side of undercorrection. Exactly, that's what I do. I do gentle pressure, and exactly the prolapsed fat that is coming out of the opening of the septum, I do remove it. However, sometimes in cases where I feel that they have a tendency of hollowness, I can even leave more fats and just cauterize those fat pads so that they fill the proper volume that I want. So again, it's not just gentle pressure, it's evaluation of the whole case from the beginning and how much fats do they really need post-operative. Sometimes you will notice that the texture of the fats itself is very, you feel the fats are very fragile. They're not, they don't have this strong constituent. So in those cases, also I will always tend to preserve more fats than needed because they have a tendency for fat atrophy. Is taking out the fat pads affect the fat in the upper eyelid? No. For this to happen, to remove so much fat from the lower eyelid so that it affects the upper eyelid, it means that you've been very, very, very aggressive in removing the fats. But no, usually it does not affect it in a direct way. Why cauterizing the remaining fat affect the healing? No, it does not affect the healing at all. On the contrary, it makes the fat rest in a very proper way over the orbital rim, and it kind of sticks to the periosteum, which provides a very good volume. Redo surgery shouldn't be harder if in the primary surgery you respected the anatomy, you did not do very harsh manipulations, you did not use cautery. And here I'm talking about cautery in the conjunctiva and the orbicularis muscle. But cauterizing the fats is never a big issue. Just avoid too much cauterization so that, again, as we mentioned in the beginning of the presentation, it does not cause any affection to the lymphatic drainage of this area. But they do surgeries, and again, if it's your own surgery, you should know somehow how you handle issues. The thing that is much more challenging is to do a revisional surgery after another surgeon. That's where you always cannot expect what you will find. But again, if you respect the anatomical layers and you're not very aggressive handling the tissues, you shouldn't find any difficulty. Of course, it's not like dealing. I think you can give us يعني a better idea about this, Dr. Bassem. But I'm not a big fan of this procedures, honestly. If you have experience with this, I would love to hear from you. But from what I've seen and from the feedback of the patients and from everything, it's nothing to be compared with surgeries at the end of the day, honestly. Yes, it's it's those kind of things that they promote, and they're very tempting for the patients that are scared from the surgery or do not want to do surgery, maybe for financial reasons, maybe because they're not ready for surgery psychologically or anything. But no, I will never, as far as the instruments that we have now. Okay, and thank you very much for being here and for listening the presentation. If anyone would like to reach out for any question, anything, I think you can do that through the academy, and they can pass my number. If anyone has any question, I'll be always happy to have you. Thank you very much, and best of luck.